Clinical manifestations of a myocardial infarction, also known as an MI, include pain or discomfort between the neck and the navel. The patient may have associated dyspnea, which is difficulty breathing, nausea, and vomiting. Cardiac failure decreases the contractility and reduces the ability of the heart to meet the needs of the body tissues. The clinical manifestations of emphysema is enlargement of the small air sacs on the distal and terminal ends of the bronchioles. The disorder is typically characterized by thick mucus and decreased elasticity of the lung tissue, and the enzymes damage the walls of the alveoli, and gas exchange is decreased because of the decreased surface area due to the damage of the alveolar structure. Cause of emphysema may relate to cigarette smoking, exposure to pollution, and or a family history of emphysema. Smoking cigarettes is the main risk factor for COPD because it leads to the oxidative stress, lung destruction, and inflammatory process, and interfere with the lung's ability to repair. In chronic bronchitis, damage to the lining of the airway occurs, causing increased difficulty in clearing of the mucus, which is the destruction of the cilia that are located in your bronchi, which move the mucus up and out of the lungs and cause you to cough and expel mucus. Environmental exposure, including smoking, pollutants in the environment and at work, and secondhand smoke increase the risk of developing chronic bronchitis. Frequent bronchopulmonary infections may contribute to COPD, pulmonary insufficiency, and chronic pulmonary emphysema, pneumonia, atelectasis, asthma, and tuberculosis, and other orders that contribute to respiratory disease. Asthma is associated with an intermittent cough, difficulty breathing, chest tightness, allergies, and wheezing heard on auscultation. Asthma may begin in childhood and continue into adulthood and may be inherited. The symptoms of asthma are airway spasms, obstruction, and inflammation. The main feature of asthma is the reaction of the airways to stimulants by irritants, allergens, pollutants, or cold air through constriction of spasms. Clinical manifestations of pneumonia include fever, cough, increased secretions, and difficulty breathing. If aspiration is determined to be a contributing cause, swallow precautions are implemented, including thickened liquids and having the patient in an upright position for feeding and drinking. Causes of atelectasis may include decreased movement of the diaphragm and chest wall, which results in hypoventilation. The process may lead to small airway obstructions from retained secretions, and patients who have led abdominal or chest surgery are at extremely high risk due to pain from deep breathing. Untreated chronic lung disease may result in respiratory failure. Respiratory failure typically occurs when the body is unable to maintain sufficient oxygenation to tissues because of disease or injury to the lungs. Early intervention for the disease or injury helps prevent respiratory failure. Taking the vital signs that include the blood pressure, the respiratory rate, and both an apical and peripheral pulses. The pericardium of the chest is visually inspected, noting any muscularity or muscular abnormalities, and the use of muscles for breathing is evaluated. And we would consider that to be the use of accessory muscles or other things to breathe. The nurse begins this physical assessment by obtaining a set of vital signs, then performing cardiac and respiratory and peripheral vascular assessment looking for alterations, and that would include taking the radial pulses, the pedal pulses, and the posterior tibial pulses to ensure that there's proper circulation to those areas. Blood pressure should be taken in 3 positions. You can do that lying, sitting, or standing. And the apical and peripheral pulses are compared to determine if a pulse deficit occurs. This is oftentimes done when a nurse is feeling the radial pulse while listening to or auscultating the heart. A pulse deficit occurs when the apical pulse rate is higher than the peripheral pulse rate due to some cardiac contractions not resulting in peripheral perfusion. The use of accessory muscles may indicate respiratory distress, and the nurse looks at the pericardium and notes any movement of the chest wall when the heart contracts. Left ventricular hypertrophy may cause the chest wall to move with each heartbeat. Evaluate the shape of the chest. Barrel-shaped chest may include air trapping, which typically accompanies COPD. A cough may be caused by inflammation or mechanical or chemical stimulation to the cough receptors in the lung. When taking the history, determine how long the cough has been present. Note if the patient has a fever or wheezing. If sputum is present, note the amount and the characteristics of the sputum. Hemolysis or hemoptysis is the presence of blood in the sputum. Describe the characteristics of the blood, or whether it flecks, it streaks, or flank bleeding. Ask the patient if the cough is related to different seasons, which may indicate an allergy problem. Edema can occur from excessive fluids in the vascular system that increase the pressure in the capillaries and forces the fluid out. Poor venous return may contribute to peripheral edema, particularly in the lower extremities. Another contributing factor would be damage to the lymphatic system, which may decrease the ability of the lymph system to remove excessive fluid from the interstitial spaces. Patients with cardiopulmonary problems may have thready or absent peripheral pulses and changes in skin color and texture, and a slow capillary refill, which would be less than 3 seconds, or greater than 3 seconds, excuse me. So a laboratory assessment is used to determine if the patient has chemical imbalances or abnormal substances in the blood. Diagnostic tests are performed to determine the function and the structure of the heart-lung tissues. The normal forced vital capacity, which is FVC, is about approximately 4 liters. In emphysema, 50% of the predicted value may be the result. The abnormal finding is indicative of air trapping and obstruction of the small airways with plugs that decrease flow rates. The expected findings for the forced expiratory volume varies by body size. If emphysema is the result, 25% of the predicted value of the patient's size. A low value is predictive of airway trapping in the patient's small bronchioles. The expected finding of the RV is 1.2 liters. In emphysema, the result may be up to 4 times the expected finding, or approximately over 4 liters. The predicted volumes for the FRC is 2.3 liters. In emphysema, it may be increased to approximately 200% over the expected amount related to air trapping. RBCs, hemoglobin, and hematocrit indicate oxygen carrying capacity. Hemoglobin may be decreased in patients with heart failure due to excessive fluid in the system causing hemodilution. It may be increased in COPD and patients due to overproduction of RBCs stimulated by low oxygen levels with a resultant increase in hematocrit. An elevation in these WBCs indicates an infection, and the differential count of white blood cells will shift to the left with neutrophils increasing and basophils decreasing. The basic metabolic panel is a series of blood tests that are used to assess the renal, glucose, and electrolyte balances in the body. Patients with heart failure, for example, or hypertension, may be on diuretics, and some of which may cause hypokalemia or hypomagnesium. Many electrolytes imbalances can cause cardiac arrhythmias. COPD causes impaired gas exchange, leading to decreased oxygen levels and a higher circulating level of carbon dioxide, or what we would call respiratory acidosis. The evaluation of the cardiovascular and pulmonary system includes assessment of blood components, including blood counts, lipids, and cardiac enzymes. Non-invasive assessments include the 12-lead EKG, a chest X-ray, echocardiogram, and physical assessments. Invasive assessments may include cardiac catheterization to evaluate coronary artery and cardiac structures. The lipid profile usually consists of 4 tests. That would be your total cholesterol, low density lipoproteins, which are your LDLs, and your high density lipoprotein cholesterols, which is your HDLs, and your triglycerides. Cholesterol is evaluated further by measuring the high density lipoproteins, or your HDLs, and the LDLs, and the total cholesterol over 200 is considered high. The target for the HDL is greater than 60 milligrams per deciliter, and for LDLs, the desired value is less than 100 milligrams per deciliter, and for triglycerides to be less than 150 milligrams per deciliter. And basically, that is a 3-to-1 ratio, so your high density lipids are the good lipids, and your low density lipids are the bad lipids. So you want 3 high density lipids to 1 low density lipid. The cardiac enzymes that are tested for are MB, CPK, troponin I, and myoglobin. The cardiac troponin T and I are the most helpful in determining if a myocardial infarction has occurred.